Good morning, everyone. Today we will be dealing with the topic concepts in cavity preparation. The contents include introduction, tooth preparation terminologies, tooth preparation walls, tooth preparation angles, objectives of tooth preparation, factors affecting tooth preparation, initial tooth preparation stages, which include the outline form and initial depth, primary resistance form, primary retention form, convenience form. The next heading include the final tooth preparation stages, which include the removal of remaining pit and fissure, caries dentin, all restorative material, pulp protection, secondary resistance and retention form, finishing external walls, cleaning, inspecting and shaping, and the conclusion. So coming to the introduction, as we all know, operative dentistry was once considered to be the entirety of the dental clinical practice. But with the advent of refined techniques, sophisticated instruments, and expert knowledge, which enable us to define operative dentistry as a diagnosis, prevention, and treatment of defects of natural teeth. These defects may be dental decay, erosion, abrasion, attrition, hyperplasia, hypocalcification, discoloration, and trauma. And it is estimated that around 60 to 80% of the cases that a dental clinician treat belong to the above mentioned defects. So the tooth which we are treating may require intervention due to various reasons. And during the tooth preparation, there should not be any much pressure or heat that can be generated from the instrumentation, or which can be due to high-speed rotating birth without coolant. And these all can damage the pulp. And every effort must be taken to limit the risk of iatrogenic damage to adjacent tooth surfaces and the tooth itself that is being prepared. So coming to the pioneer in dentistry, Dr. G.V. Black, and he's known as a father of operative dentistry, and he classified dental caries. He gave the operating instrument formula and the instrument classification. And in 1871, Dr. Black gave the philosophy of extension for prevention, or the cutting for immunity concept in the tooth preparation ideology. But nowadays, the macro dentistry, which was proposed by G.V. Black as the extension for prevention, has a paradigm shift. And nowadays, with the advent of newer instrumentation and newer materials, the micro dentistry, that is prevention of extension, is in. So coming to the tooth preparation terminologies, which include the tooth preparation means the mechanical alteration of a defective or the injured or diseased tooth to receive a restorative material that reestablishes a healthy state of the tooth, including aesthetic corrections which were indicated and normal form and function. And cavity can be defined as a simple word as any breach in the surface integrity of the tooth. And isthmus, and this is known as the narrowest portion of the cavity preparation on the occlusal surface of a tooth. And we all know class 1, class 2, class 3, class 4, class 5, class 6 preparation. And the class 1 preparation, the isthmus is located between the mesial and the distal dovetails. And in the class 2 preparation, as we can see in the picture, the transition between the occlusal and the proximal cavity is termed as isthmus. And this is the narrowest place of preparation, and it is of fundamental significance for retention of the filling. The next terminology is the cavous surface angle. And here we can see the cavous surface angle means the angle of the tooth structure formed by the junction of the prepared surface and the external surface of the tooth. And the actual junction is the cavous surface margin. There are two types of tooth preparation: simple tooth preparation, compound tooth preparation, and the complex tooth preparation. So the simple tooth preparation, the preparation that involves only one surface of the tooth. And here we can see that in the picture, there's only the occlusal surface is involved. And in the next one, we can see that which includes the two surfaces of the tooth. And a complex preparation which include more than 3 or more surface of the tooth. So here we can see it includes the occlusal, distal, and mesial surface of the tooth. There are two types of other classification, that means the conventional preparation and the modified preparation. The conventional preparation which we are using for amalgam, gold and ceramics, which include specific depth, walls and marginal form depending upon the restorative material. But nowadays, by the use of newer materials like composite, glass enamel, cement, etc., there is less need for the specific depth, walls and marginal forms, and these are usually used for the bonded direct restoration like composites and GIC, and they are known as the modified preparation. Next terminology is with the tooth preparation walls. We all know that there are internal walls and external wall. An internal wall, it is the prepared surface that does not extend to the external surface of the tooth. So this is the internal wall, and it consists of two types. There is the pulpal wall and the axial wall. Pulpal wall is the internal wall that is perpendicular to the long axis of the tooth and occlusal of the pulp. And axial wall is, as we've seen in the class 2 cavity, the internal wall that is parallel to the long axis of the tooth. An external wall, it is the prepared surface that extends to the external tooth surfaces and take the name of the surface to which it is made or it is toward. There is a distal wall, mesial wall, facial or buccal wall, lingual wall and gingival. These all can depicted in the diagram. Other terminology is the floor or seat. The floor means the prepared wall that is reasonably flat and perpendicular to the occlusal forces directed occluso-gingivally. So this can be the pulpal floor or the gingival seat as seen with the class 2 cavity. Then we have the enamel wall and the dentinal wall. Enamel wall, as the name suggests, it is the portion of the prepared external wall consisting of enamel. And dentinal wall, it is the portion of the prepared external wall consisting of dentin in which the mechanical retention forces features may be located. Next is the tooth preparation ankles. There are line ankles and point ankle. The line ankles, here the junction of the two plane surface of different orientation along a line. And they can be internal line ankle whose apex points into the tooth and the external line ankle whose apex point away from the tooth. And point ankle, the junction of three plane surface of the different orientation at a point is known as the point angle. So these are the line ankles and point ankles for the class 1 cavity. The line ankles of a class 1 cavity include 8 in number and the point ankles include 4 in number. Here we can see that there is a mesiofacial line ankle, then mesiolingual line ankle, then mesiopulpal line ankle, then we have the distofacial line ankle, distolingual line ankle, distopulpal line ankle, then we have the faciopulpal line ankle, then the linguopulpal line ankle. And the point angle, we have already seen that a point angle means a three planar orientations are meeting at a point. So they include the mesiofaciopulpal point angle, then mesiolinguopulpal point angle, distofaciopulpal point angle, and the distolinguopulpal point angle. For the class 2, this is the diagram showing the line angles and the point angle. The name, as we have seen in the other things itself. So the line angles, the name include the distofacial, distolingual, distopulpal, axiofacial, axiolingual, axiopulpal, axiogingival, then faciopulpal, faciogingival, linguopulpal, and the lingogingival. Point angles are 6 in number, which include distofaciopulpal, distolinguopulpal, axiofaciopulpal, axiofaciogingival, axiolinguopulpal, and axiolingogingival. In the class 3 cavity, there are 6 line angles and 3 point angles, as we can see in the picture. The first one is the faciogingival line angle, then the lingogingival line angle, as we have seen here. Then we have the axiofacial line angle, then the axiolingual line angle, then the incisal line angle, then the axiogingival line angle. The point angles, here they are the, here we can see the point here, axiolingogingival line angle. Then there is the opposite side, we have the axiofaciogingival line angle and the axioincisal line angle. In class 4, the line angles are point angles. The line angles are 11 in number and the point angles are 6 in number. And the names are given below. And in class Y cavity, which includes the smooth surfaces, mainly to the cervical or the gingival, It includes the eight line angles, which are the axiogingival, axioincisal, axiomesial, axiodistal, mesioincisal, mesiogingival, distoincisal, and the distogingival. The point angle include 4 in number. They are the axiodistoincisal, then the axiomesioincisal, then axiodistogingival towards the gingival surface, and the axiodistogingival. So here is a nutshell of the type of tooth preparation, the line angles and point angle. Just a refreshing, class 1 includes 8 line angle and 4 point angle. Class 2 includes 11 and 6 in the point angles. Class 3, 6 line angles and 3 point angles consecutively, and class 4, 11 line angles and 6 point angles, and class 5, 8 line angles and 4 point angles. Then coming to the main topic, that is the objective of tooth preparation. So the main objectives of tooth preparation include, we have to remove all the defects and provide the pulp protection of the tooth, and to extend the preparation as conservatively as possible. That means we have to conserve the tooth structure as much as possible, and form the tooth preparation so that under the force of mastication, the tooth or the restoration or both will not fracture and the restoration will not be displaced. Allow for the aesthetic and functional placement of the restorative material. So these are the 4 points which we have to keep in mind while we are going for a tooth preparation. And the factors affecting tooth preparation, that can be divided into 3 general headings. It is general factors, patient factors, and restorative material factors. The general factors include diagnosis and knowledge of the dental anatomy, that is the tooth structure. The patient factors include the age of the patient, the level of the caries risk, then the aesthetic concern of the patient, medical condition of the patient, and the economic status. And the restorative material factors include the physical properties of the material and the adhesive mechanism of the restorative material. And broadly, we can classify the stages of tooth preparation into 2. Stage 1, the initial cavity preparation, and stage 2, the final cavity preparation. In the stage 1, we have 4 headings: the outline form and initial depth, primary resistance form, primary retention form, convenience form. In stage 2, we have 5 headings that include the final cavity preparation, which include removal of any remaining pit and fissure, infected dentine, all restorative material, pulp protection, secondary resistance and retention forms, finishing external walls, cleaning, inspecting, conditioning, and sealing. So this is a picture or a diagram of the outline form and initial depth of a cavity. So outline form, the outline form can be defined as placing the preparation margins in the position they will occupy in the final tooth preparation, except for finishing enamel, walls, and margins. So in other words, we can say that this is the perimeter of the preparation in width, length, and depth dimensions. And we have an initial depth of 0.2 to 0.8 millimeter into the dentine. Here we can see in the diagram, the burr blade, there is a relation to the central fissure, that is a 1.5 mm or half the length of the burr head. And in the relation to the cavus surface margin, it can be either 2 mm or the 2/3 the length of the burr head. So whatever tooth preparation we are making, the type, outline form, etc. should be designed that all the unsupported and the weak or the friable enamel should be removed, and all the folds in the tooth surface should be included, and the preparation margin should be placed in positions that allow us to inspect and finish the subsequent restoration margins. The outline form and initial depth are determined by several factors, which include the extension of the caries, whether it is a class 1, class 2, or class 5, class 3, whatever it may be, and the restorative material should be used, the aesthetic considerations and relations adjacent opposing teeth, and proximity to other defects. The features of the outline form and initial depth include the cuspal strength should be preserved, and the marginal ridge should be preserving the strength of the marginal ridge. Then we have to minimize the buccolingual extension of the cavity, and we have to connect the folds which are less than 0.5 millimeter apart, and we have to limit the preparation depth into 0.2 to 0.8 mm into dentine. And while we are making the outline form, it should be modified such that the margins will be in no margins will be in occlusion with the opposing tooth. And enameloplasty, that we know that the term enameloplasty, that means the removal of the sharp and irregular enamel margins, and this can be either done by rounding or saucerizing, which can convert the cavity into a smooth groove, which will be self-cleansable. Coming to the outline form of a pit and fissure caries, here in the diagram we can see the pit and fissure caries. We have to remove all the weak and friable enamel and extend the cavity outline into the sound tooth structure. The outline form should comprise of smooth curves, that should not be any sharp edges or something like that. And this is known as a circumventing of the cusp, and avoid extension onto high stress area like cuspal eminences. And the isthmus width, that is isthmus width should be around 1/4 of the intercuspal distances. The actual depth of the preparation can vary from 1.5 to 2 millimeter, and this can depend upon the steepness of the cuspal slopes and enamel thickness. And we have to extend the margins to include all pit and fissures which cannot be managed by enameloplasty. Then the outline form of a smooth surface caries, it's a class 2 cavity that include the extent of the caries and the contact area with the other tooth and the relationship with the other tooth, then the age of the patient, then position of the gingiva, whether it is supragingival or subgingival, then the alignment of the tooth and masticatory force, and the aesthetic requirements. So in the case of a class 2 cavity, we have to extend the preparation till the sound tooth structure should be reached. And in the case of the axial wall, that should be parallel to the external surface of the tooth, and that should be placed 0.5 to 0.8 mm into the dentine enamel junction. And we have to follow the curvature of the DEJ buccolingually and occlusogingivally. Buccolingually, there is a proximal preparation should clear the adjacent tooth by at least 0.2 to 3 millimeter. And in the case of a gingival seat, it should be placed apical to the contact area, that is occlusal to the gingival margin, and the clearance of 0.5 millimeter from the adjacent tooth. So the occlusal clearance, the gingival seat, it should have a clearance of 0.5 millimeter from the adjacent tooth. And buccolingually, the proximal preparation should clear the adjacent tooth by about 0.2 to 0.3 mm. Then in the case of class 5 cavity, which is placed on a smooth surface, either cervically or gingivally, that should be determined by the extent of the lesion, and the extension can be made either mesially, distally, occlusally, and gingivally till the sound tooth structure should be reached, and the axial depth is limited to 0.8 to 1.25 mm pulpally. And in general to the normal outline form, for the class 5 preparation, we have to consider gingival margins, and there should be enough of the attached gingiva. The term which we have earlier discussed, enameloplasty, it is termed as the, or either defined as the removal of sharp and irregular enamel margins by rounding or saucerizing it and converting it into a smooth groove, making it into a self-cleansable area. And the indications of enameloplasty include caries in less than 1/3 thickness of the enamel, and presence of shallow fissure crossing the facial or lingual ridge, and in case supplemental groove extend to the cuspal inclines. Then significance, the enameloplasty, it should not extend the outline form, that should be within that outline form. And the main fruitfulness of the enameloplasty include that it makes the area self-cleansable, finishable, allowing conservative placement of the margins, and it should not be used unless a fissure can be made in a saucer-shaped area with mild removal of enamel. It should not reach dentin, and it produces more tuning of the tooth surface and the restorative material. And enameloplasty is accomplished by using a large round burr or a ball-shaped diamond stone, and this can be followed by appropriate finishing burrs. Then the enamel or dentin, whether we are reaching the enamel or dentin with preparation, that can be distinguished by the color, then the reflectant, sound, and the tactile sensation. In the case of color, dentin is more yellowish white in color, and enamel is a translucent grayish white. While reflecting, the dentin surface is more opaque and dull, being less reflective to light than enamel surface, which appears more shiny. Sound, there is a dull sound for the dentin, but in the case of enamel, there is a higher pitch of enamel when we are moving the explorer across the tooth surface. And the tactile sensation, dentin will be having a greater yielding to pressure than enamel. Then coming to the second stage, there is a primary resistance form. The primary resistance form can be defined as the shape and placement of the preparation walls to best enable both the tooth and the restoration to withstand without fracture the stress of masticatory forces they elevate principally along the long axis of the tooth. So to best resist masticatory forces, we have to use floors or planes at right angles to the direction of the loading to avoid the shearing stress. Then if possible, walls of the preparation should be parallel to direction of the loading forces in order to minimize or avoid the stresses. And intracoronal, that is within the crown, or intraradicular cavity preparation can be done in a box, cone, or inverted truncated cone shapes to make the primary resistance form. So these are the diagrammatic representation. You can see that the box shape of the cavity, it is also known as the mortise form. Then there should be the flat pulpal floor. Then the rounding of the internal line angles. There should not be any sharp corners. That is the rounding of the internal line angle. And the restorative material should be having adequate thickness. So in the case of an amalgam restoration, it should be having at least 1.5 millimeter. Then the butt joint should be there. Then should be the convergence of the parallel walls, and then rounded line and point angles, and the bulk of the restoration should be at least 1.5 mm along with the flat pulpal floor. Then depending upon the type of restoration, the minimal occlusal thicknesses should be, in case of cast metal, it should be around 1 to 2 mm. For amalgam, at least 1.5 mm. Ceramics, 2 mm. And composite, it is 1 to 2 mm. Another terminology is cusp capping, which means there is a coverage of the weakened cusp to prevent the fracture. So if the cusp is not properly covered or coverage is not properly provided, this will lead to cusp fracture. So during the cavity preparation, due to the extent of caries or any other reason, the preparation may end up in the cuspal incline, so the intercuspal distance will increase, and which can reduce the strength of the cusp. So the cusp will be so weakened that they are not able to bear the masticatory force, and they may undergo fracture. So if the preparation margin is extended 2/3 of the distance or more, the cusp capping must be necessary. So it is to protect the weak underlying cuspal structure from fracture by masticatory forces and to remove the occlusal margin from region subjected to heavy stress and wear. So there are certain rules for cusp capping, which include if the extension from a primary groove toward the cusp tip is no more than half the distance, then no cusp capping is necessary. And if the extension is more than 1/2 to 2/3 of the distance, then we can consider cusp capping. And if the extension is more than 2/3 of the distance, then capping must be mandatory. So in the picture, we can see this. The dotted picture shows that it is okay for restoration. There is cusp capping is not necessary. But in the without cusp capping. So next one, this shadowed area here, the extension is more than 1/2 to 2/3. We have to consider capping, and in the board line we can see that the 2/3 or more of the distance is included, and the capping must be mandatory to preserve the cuspal strength. Then comes the primary retention form. So the primary retention form is defined as that form, shape, and configuration of the tooth preparation that resists the displacement or removal of the restoration from the preparation under lifting and tipping masticatory forces. So the retention form can be divided into two types, that is according to efficiency and according to location. According to efficiency, they are two in number. There is a principal type and the auxiliary type. And according to the location, they are the intracoronal and the extracoronal, that is placed within the crown structure or outside the crown structure. So the principal means of retention include frictional retention, then the elastic deformation of dentine, inverted truncated cone shape or undercuts, and the dovetail. Then the auxiliary means include the grooves, internal boxes, pins, etching, and the last one, the occlusal loading consideration. So the auxiliary means of retention, the grooves, they are placed in dentine whenever the bulk of the dentine metal allows for that without undermining the adjacent enamel. And the internal boxes, that should be with definite walls and floors, and pins. Example, in amalgam, we are giving pins that should be parallel, either parallel, non-parallel, vertical, horizontal, threaded, or cemented. And etching or acid conditioning in the case of composite. And if the restoration is designed so that the occlusal loading is directed to seat the restoration rather than to displace it, it is an ideal auxiliary form of retention. And we have seen that the principal mode of retention is the auxiliary dovetail, then elastic deformation of dentin, then there should be an occlusal convergence. The shape should be converging towards the occlusal surfaces around 2 to 5 degree, and there should be a slight undercut which is made in dentin near the pulpal wall. Then retention features for cast restoration include there should be a close parallelism of the opposing wall with an occlusal divergence that is around 2 to 5 degree, and we have to give a reverse bevel in class 2 compound, then MOD cavities. Then secondary retention features like curves, skirts, and ending slots can be given, and an occlusal dovetail can also be given for a class 2 preparation. Then in composite, the micromechanical bonding between the edged and the framed tooth and the composite surface. Then we have given the enamel bevels. Then retention features in direct filling gold that will be created by the elastic compression of dentin. And the starting point in dentin provide the retention by proper condensation of the direct filling gold. Next is a convenience form. Convenience form can be defined as that form which facilitates and provides adequate visibility, accessibility, and ease of operation during preparation and restoration of the tooth. Then the convenience form features include, we should have an adequate width and lateral extension of the cavity. Then it should provide proximal clearance from the adjacent tooth to provide occlusal divergence for the cast gold inlays, and there should be a refining of the line angles and point angle for starting points in case of direct filling gold. So ideally, tooth preparation should have all the requirements for outline, resistance, and retention forms, and which should be used for the convenience of the instrumentation. So coming to the final stage of tooth preparation, this include removal of any remaining enamel pit or fissure, infected dentin restorative material, pulp protection, secondary resistance and retention form, finishing of the external walls, cleaning, inspecting, and sealing. So removal of any remaining enamel pit or fissure, infected dentin restorative material, we should remove only the infected dentin and not the affected dentin, and this can be either done by a large round steel bar at a slow speed, large spoon excavator, and nowadays we have the smart prep burrs. These burrs are round burrs which are used at a speed of around 500 to 800 rpm. Their hardness is greater than the infected dentin but lesser than the normal enamel and dentin, and they will not cut through the normal enamel and dentin. So when to remove the old restorative material depends upon the secondary caries, whether there is secondary caries which is present beneath the restoration. If there is a tooth is having any symptom, then it affects the aesthetic of the new restoration and the marginal deterioration of the old restoration. So as I said, the smart prep instrument, smart burrs that can be used to remove decay and deeper lesions, and that will protect against the unintentional pulp exposure, and this can be used for patients who have a needle phobia or they prefer local anesthesia. And these are hard enough to cut only decayed dentin, they will not cut through the healthy dentin. So next come the pulp protection. We know that due to the tooth preparation, if due to either instrumentation or without using a coolant, etc., the heat may be generated, and this can affect the pulp. So when the remaining dentin thickness is less, pulpal injury can occur because of either heat production, irritating restorative materials, then high-speed burr with less effective coolant, then ingress of the microorganism through the micro leakage of the restoration, or the galvanic current from dissimilar materials. While we are placing two different types of metal, either amalgam or gold or something like that, galvanic currents can be produced. So pulp protection should be done with the depth of the tooth preparation. So we can see that here the type of the preparation is given, and the remaining dentin thickness that can be classified into three. That is a shallow type, that is the remaining dentin thickness is more than 2 mm, and moderately deep, that is the remaining dentin thickness is between 0.5 to 2 mm, and the deep means the remaining dentin thickness is very much, that is less than 0.5 mm. So in the case of a amalgam restoration, if there is a shallow RDT, then varnish can be used. Moderately deep, we can go for a base, and in case of deeper condition, we can go for a calcium hydroxide, which can be used as a sub-base, and that should be covered with a base. In the case of glass ionomer cement, shallow, even if it is shallow, there is no pulp protection is required. Moderate deep also, pulp protection is not required. And in the case of deep deep cavity, that is RDT is less than 0.5 mm, calcium hydroxide liner can be used. In the case of a composite restoration, for a shallow one, dentine bonding agent is used, and for a moderately deep hole, so that is between 0.5 to 2 mm, dentine bonding agent is used, and in deeper cases, calcium hydroxide liner followed by glass enamel cement as base. And for the cast gold restoration, for a moderately deep one, we are giving a base, and for a deeper one, we are going for a calcium hydroxide liner with a base over it. So cavity liners can either be calcium hydroxide or glass enamel cement. Cavity sealers can be used as varnishes are there, then the resin bonding agents, and bases, as we know, the different types of cement, which include zinc oxide eugenol, zinc phosphate, glass enamel cement, polycarboxyls, etc. The glass enamel cement, this can be used as a liner under composite resin to reduce the micro leakage from composite restorations. And the main advantage is that they are chemically adhesive, anti-carcinogenic, and there is less solubility, and the biocompatibility is very much higher. Disadvantage is that it is sensitive to moisture contamination. Then coming to bases, these bases are applied in thicker layers to provide thermal protection to pulp and to supplement mechanical support for restoration by distributing local stresses to the underlying dentine, and they provide support during condensation of amalgam if the remaining dentine thickness is very much less. Then the mode of application, the consistency of the base or the liner is very much important. A small sesame seed-like material is taken to the tip of the explorer, and that is carried in the cavity. They are applied on the pulpy floor and the axial wall, and an ultra small cotton pellet is held with a cotton plier, and the metal is padded and adapted to the cavity flow. So the different metals used as base and their advantages: zinc oxide eugenol, then zinc phosphate cement, GIC, and the polycarboxylate cement. Then the secondary resistance and retention forms include, this is used usually in the more complex and compound tooth preparation, where added preparation features are used to improve the resistance and retention form of the prepared tooth surface. And this can be done by adding the mechanical features or the conditioning procedures. Mechanical features include the retention grooves. They are placed in the axiofacial or the axiolingual line angle from the gingival floor to the occlusal surface. And these are provided with the number 1/4 round burr just inside the dentine. Then location of retention grooves include class 2 preparation, the proximal wall at the axiofacial and axiolingual line angles, as we can see in the diagram. Then for the class 3 preparation, the axiogingival line angle or the axiofacial gingival line angle and the lingual dovetail. And for the class 5 preparation, it is given on the axio-incisal and the axiogingival line angle. We should be remembering the cavity line angles. The curves, they are smaller conical depressions which can be provided in the class 2 preparation at the axiofacial or the axiolingual line angle, and these will be used to resist the proximal displacement of the restoration. Then other one is a slot or the internal blocks. These are 1 to 1.5 mm box-like groups which are provided in the dentine to increase the surface area. So either they are prepared in the occlusal box or the lingual axial line angle or the gingival walls. And other one is the logs, as we can see in the diagram. They are prepared in the class 2 amalgam restoration for increasing the resistance and the retention form. The other mode of retention, secondary retention form, is the skirt. They can provide additional retention in the cast restoration by increasing the total surface area of the preparation. So these are either prepared on one side or all the four sides of the preparation using a flame-shaped burr, which will increase the surface area. Then the other one is the amalgam pins. So these are used in the amalgam restorations where the vertical posts of the amalgam are anchored onto the dentine. So we have to prepare a dentine chamber by using an inverted cone burr, and on the gingival floor it should be 0.5 millimeter into the dentine, and the width should be around 0.5 to 1 mm. So so usually these are formed into the amalgam, as we can see from the picture. And in case of the conditioning procedure, like for composite etching and bonding, this will increase adhesive property of the tooth preparation, and this can go for the procedure in GIC, composites, and ceramics. Then finishing external walls of the preparation. Finishing of the tooth preparation walls is the further development of the cavus surface defined as we have seen earlier, and degree of the smoothness which produce maximum effectiveness of the restorative material being used. So the objectives include, we should have a smooth marginal junction between restoration and tooth surface, and it should provide maximum strength for both tooth and restorative material at and near the margins, and it should provide smooth blending of the restoration and tooth surface at the margins. And the type of the finishing necessary depends upon direction of the enamel road, then whatever material we are choosing as a restorative material, and location of the margin of the cavity. The final stage is the cleaning, inspection, and sealing. These steps will include the removal of the debris and drying of the preparation, final inspection before placing the restorative material. And the tooth surface should be, tooth preparation can be cleaned using a warm water, and we have to dry the tooth preparation using air, dry cotton pellets, etc. And the sterilization of the prepared walls with mild alcohol-free disinfectant. Cavity cleansers can be used for the cleaning of the cavity. They will disinfect the cavity prior to the application of the restorative material. They are usually the benzalkonium chloride or chlorhexidine products, gluconate products, and they can be applied directly onto the prepared tooth surface to disinfect the area that will be sealed under the restoration. Then here there's a small diagrammatic representation of the cavity preparation for amalgam. So the outline from an initial depth, we have to extend the preparation margins to place they will occupy in the final preparation, as we can see here. Then avoid entering preparation margin in high stress area like cusp tip and crest of the ridges. Then place the margins on the sound tooth structure. The outline form for different. So then mandibular first molar, it should be either bad shape. For the mandibular first premolar, a snake eye shape. Then here we can see the butterfly shape. Then for the mandibular second premolar, that could be a plus shape. Then mandibular second molar, it is a plus shape, and mandibular second premolar, that could be a Y shape. Then for the maxillary premolars, that is butterfly shape, as we can see here. In the case of maxillary first molar, kidney shape for the mesial cavity. Then the burr we are using is number 45 to 45 burr for the grading the preparation. We can see the picture of the number 245 burr. The depth of the cavity preparation, that should be 1.5, that is half the length of the burr. Width of the marginal lid should be 1.62 mm, that is double the burr width. Then there should be a rounded internal line angle. This is achieved by the rounded corners of the burr, as you can see here. Then convergent external bows, that is made by the pear-shaped structure of the burr. The steps should be the initial punch cut is made with burr parallel to the long axis of the tooth, and we have to maintain the initial depth of 1.5 millimeter from the central fissure at least 0.2 to 0.5 millimeter into dentin. Then we have to maintain the same depth and burr orientation. Burr is moved to include the defective pits and fissure. Then they extend the margin mesially as well as distally without involving the marginal ridges, and it should have a dovetail shape for retention. Then the isthmus width should not be more than 1/4 intercuspal distance, and the deep pit and fissure defect less than 0.5 millimeter apart are included in the outline form. All the unsupported demineralized enamel should be removed. External form should have smooth curves and rounded angles, and enameloplasty, as we have discussed, should be done if required, and this can remove the sharp irregular enamel margins, and that can be converted into a self-cleansible area. So the primary resistance form of a class 1 cavity, amalgam cavity, include the box-shaped cavity, flat flows, then adequate depth of the preparation. There should be adequate material thickness, then 90-degree cavous surface angle or a butt joint, then the marginal ridge areas with strong dentin support, rounding of all internal line and point angle, cuspal strength preservation by smooth free-flowing outline form and circumventing the cusp. Then primary retention form features including 2 to 5 degree occlusal convergence and occlusal dovetail. Convenient form features sufficient width of the preparation for ease and accessibility of the instrumentation. Then the final cavity preparation, which include the removal of all the remaining caries, dentin, all restorative material, adjacent deep pits and fissures which are involved in the preparation, and larger preparation with stop caries. This step can be done either with a spoon excavator or a slow speed round bar, resulting in a stepped or a 2-level pulpal floor as necessary. So this is the diagrammatic presentation of a class 1 cavity preparation. So as a conclusion, the ultimate goal of operative dentistry should be the restoration of the health of the tooth, and this should include the restorating form, then function, phonetics, aesthetics, and the occlusal stability of the tooth structure. And the restorative treatment should be systematically compatible with and conductive with the welfare of the whole patient. We should have a scientific as well as artistic knowledge, manual skills, and with all this, only the ultimate goal can be achieved. A tooth preparation is determined by many factors, and each time a tooth is restored, each of these factors should be considered. Now, so the factors necessary for successful tooth restoration are the ability and knowledge to remove infected dentin or and unfriable enamel, then proper manipulation with restorative material and contour of the restoration to provide form and function. Thank you all.